Hi, everybody, and welcome to the 9th lecture in our 10-part GI lecture series for those of you studying for USMLE Step 1 or COMLEX Level 1. Today, we're going to talk about the gallbladder and the bile ducts, so the hepatobiliary system. We'll start again with anatomy. We saw this anatomical relationship when we talked about the pancreas, so I'm just going to go over it one more time. So here on the top right there, you can see we have our right and left hepatic ducts. What those do is they drain bile that gets created by the liver. Both of those ducts drain into the common hepatic duct. Over here, we have the cystic duct, which is important because that's our outflow tract from the gallbladder. And the common hepatic duct and the cystic duct both combine into this common bile duct here. That common bile duct will attach to the main pancreatic duct located throughout the pancreas. This is our primary pancreatic drainage system. And as we just said, it connects with the common bile duct. So in this region, you can not only have bile, you can not only have pancreatic enzymes, but you can have bile flowing through the distal part of this tract in this region. Something I want to note right here, I added it to the screen. You also have an accessory pancreatic duct, which has no connection with your CBD, but this can still drain pancreatic enzymes through this minor duodenal papilla. At the end of the main pancreatic duct, you have your ampulla of Vater, which is a widening of the duct right here. And this helps to increase outflow of both pancreatic fluid and the fluid coming from the common bile duct, like bile. Here we have our major duodenal papilla, which is the region of the duodenum that drains the main pancreatic duct. And you have to remember that there's something called the sphincter of Oddi, which is a muscular layer surrounding that major duodenal papilla. And this can regulate outflow depending on whether it's constricted or relaxed. And the relevance that sometimes is tested, it's a little bit low yield at this point, but there's some thought that morphine can cause this sphincter to spasm. And so if you have somebody with acute pancreatitis, sometimes morphine specifically is avoided. It kind of depends. I've seen different institutions say different things about this, but I just wanted to throw it out there for you. That's it for anatomy. The gallbladder anatomy is very straightforward. Let's talk about physiology. And when we're talking physiology, I really want to go in depth about bile and all of its components. So we'll talk about bile function, composition, bile secretion, reabsorption, and finally, we'll talk about what happens when you have biliary obstruction and all the symptoms associated with that. So starting with function, there's 4 main functions you should know with bile. The first function I want you to recognize is that it helps to emulsify fats, so it helps digest fats and fat-soluble vitamins. We talked about this in the small intestine lecture, but I'll review it now. Just remember that lipids are amphipathic, and what that means is that they have a hydrophilic region, which likes water, and a hydrophobic region, which does not like water. So if this is a triglyceride here, a breakdown product of fat, you can see that on the end here, we have a hydrophilic end, and here we have a hydrophobic end. And the clinical significance of this is that if you have a fat globule in your digestive tract, what's going to happen is that the hydrophilic ends will all arrange around touching the lumen, and the hydrophobic ends will bundle together in the middle. The problem with this is that if you have pancreatic enzymes, when they try to get in and digest all of this fat, they're not going to be able to access this hydrophobic region in the middle as well, because they'll have to break through all this other stuff first. So their surface area is compromised a little bit. The good news is, though, is that bile is also amphipathic. So what bile can do is it can start binding in there and kind of break down this huge globule into a lot more small globules. And so you'll have pancreatic enzymes that can reach more surface area and break down these fats a lot easier through that process of emulsification. The second thing I want you to recognize is that bile is helpful for excreting waste products like bilirubin and cholesterol. And so if this is a bile that's in the gallbladder, it can get drained out. Once the gallbladder contracts, it gets drained into the duodenum, and then that can go out and be excreted in the stool. And what we'll find later when we talk about gallstones, we'll find that the two subtypes of gallstone are bilirubin gallstones and cholesterol gallstones, and that's because those are both being excreted and in some form within the bile. I also want you to recognize that bile can provide some alkaline fluid to counteract the stomach acid. We already saw in the pancreas lecture that the bicarbonate produced by our ductal cells in our pancreas is really helpful to neutralize that acid, but bile also plays a role in that. So if we have a bunch of hydrogen ions that made it into the duodenum, they can cause some damage, but fortunately, if you have bile there, it'll neutralize that as well to some extent. And bile also has some bactericidal activity. So when we eat food, oftentimes there's a lot of bacteria in it, and most of that bacteria gets killed within our stomach acid, but for the bacteria that makes it through the stomach, so if this is our food bolus, you can have some bacteria. Again, if it counteracts with bile there, then bile can also take out some of those bacteria to protect us. So what's bile made of? It's important to recognize that bile is made of a few things, mostly water. It's about 95% water. And then you're going to find bile salts. So the water, the electrolytes, and the bile salts will help keep it more diluted and less concentrated. And that'll be important to prevent things like gallstones forming. But you can also have cholesterol and bilirubin within this, as we've discussed. And there's many other components they're in bile, more low yield for step, but I just want you to recognize that bile is a cluster of several important compounds, most notably the water, bile salts, cholesterol, and bilirubin. So I'll draw that in a picture. So if this is our bile, just want you to realize that it's 95% water, and it's also made of these salts, cholesterol, bilirubin, and other products. And we'll go over this framework when we talk about gallstones. So how is bile secreted? Bile is synthesized in the liver, and after it's synthesized, most of it is sent directly to the gallbladder. And then once the gallbladder is activated by things like cholecystokinin, it's going to be secreted because the gallbladder will contract. So that looks like this. The liver will create the bile, and that bile will get sent to the gallbladder. And then once the gallbladder is activated by CCK, it'll contract. And then once it contracts, that bile can flow all the way down through your cystic duct, common bile duct, main pancreatic duct, the ampulla of Vater, out the major duodenal papilla, and into the duodenum. So we've talked about how bile gets into the duodenum, but how do we get some of it back? We don't want to waste all the bile. Most of it's actually reabsorbed in the intestines once it's done its job of emulsifying the fats. So the one thing it's important to recognize is that even though both bile and fat are reabsorbed, they're not absorbed at the same segment of our GI tract. So instead of being reabsorbed with the fat micelles, the bile salts get reabsorbed later on in the terminal ileum. And because of this location that it really prefers getting reabsorbed in the terminal ileum, if you have any damage to the terminal ileum, you can ultimately start having a bile salt deficiency and subsequent fat malabsorption. So I'll draw this here. If this is our lumen of our GI tract, we have our bile surrounding fat droplets, and pancreatic proteases and lipases are doing their work. In this case, lipases would be breaking this down. They can break it down into micelles, and those can flow into enterocytes. Now, bile that was just helping with that process cannot get into that same enterocyte. And instead, the bile will travel down the GI tract and before reaching the terminal ileum, and there it can be reabsorbed. But remember, if there's any damage to this terminal ileum, then you won't get any of this reabsorbed bile. So you'll lose it in the feces and the stool, and so ultimately you'll end up having less bile. And so this can cause fat malabsorption. Another thing to note when we're thinking about different cholesterol medications, there's a few things called bile acid resins, like cholestyramine, cholesevelam, and cholestyramine, and these intentionally inhibit this bile acid reabsorption by binding to the bile and not letting it escape in the terminal ileum. And so these medications will reduce your bile in your body, which reduces your fat absorption, and then so you'll likely have fatty diarrhea, but you'll lose some cholesterol in the process because you're not going to be reabsorbing all this fat. So it can have a clinical, there's a clinical utility to preventing this process as well. So now let's discuss biliary obstruction and all the symptoms associated when your bile ducts are clogged in any way. So we talked about bile being in our gallbladder and it flows out into the duodenum. What happens if it's blocked? It doesn't matter if it's blocked here or here or here, anywhere in the common bile duct or further, you're going to run into some problems. So when you have an obstruction, the bile is not going to be able to escape and it's going to leak out into our bloodstream. And what I want to do is I want to go over all the different symptoms that arise and laboratory findings as well that can arise based on biliary obstruction. I'm also going to put in the 5 components of bile, and when we talk about a symptom, I'll highlight which component of bile is predominantly causing that specific symptom. So let's kind of go over it, and I think it'll make sense. So for pruritus, if you've ever heard of somebody who has really bad liver disease or gallbladder disease like PBC, which we'll talk about later, you can get pruritus, and that's caused because as inside this bile are bile salts, and when you have a ton of bile salts in your blood, that can really cause a bad form of itching. For jaundice, so jaundice is caused by any sort of bilirubin in the bloodstream, whether it's conjugated bilirubin or unconjugated bilirubin. Dark urine is also caused by bilirubin in the bloodstream, but it's just the conjugated form of bilirubin that's causing the dark urine. And so I'm gonna show this in a graphic to make sure it makes sense to you. So normally, where are we getting our bilirubin anyways? Where's all this bilirubin being formed that we have to excrete through our bile ducts? What happens is that our red blood cells have a finite life. They only live about 3 months, right? And so when our RBCs finally die, they're going to release some bilirubin, and that bilirubin will be unconjugated bilirubin. And an important thing to recognize is that unconjugated bilirubin is insoluble in water. So it's water insoluble. So if this unconjugated bilirubin tried to go to the kidneys to get excreted, the kidneys basically throw it back in the bloodstream and say, I can't do that, because they're only going to help out with some some water soluble compounds. So now we have this unconjugated bilirubin that can't escape. It's stuck in our bloodstream. So how do we get it out? Well, the good news is our liver has some enzymes that can conjugate this bilirubin. So that will get sent here, and you'll have our UDP gluconeurotransferase that we'll talk about in the liver section quite a bit that conjugates this bilirubin. And then that conjugated bilirubin is a component of our bile, as we've discussed, and this can get secreted into our GI tract. And so that conjugated bilirubin is now in our gut. And ultimately, that's how you get rid of it. But if we have an obstruction, like we just talked about, what's going to happen is all that conjugated bilirubin now can get into our bloodstream. And this conjugated bilirubin is able to get filtered by the kidneys, and that'll result in dark urine. So pale colored stool is also is caused by bilirubin, or actually a lack of bilirubin within your GI tract. So what's happening here is that normally bilirubin that makes it to your GI tract helps provide a brown pigment in your stool. And when I talk about the last symptom here, this decreased urine urobilinogen, I'll talk about how urobilinogen can be converted, if it's in your GI tract, can be converted into stercobilin, and that kind of gives the brown pigment that you see in your stool. Now, again, if there's an obstruction, you're not going to have any bilirubin in your GI tract, and because of that, your bilirubin will stay pale. I mean, your stool will stay pale. Steatorrhea is important to recognize as well. We talked about this in the pancreas lecture. It's kind of the same idea, actually. Steatorrhea is basically fatty stools. So you'll get this diarrhea, this almost like this osmotic diarrhea because you have so much fats in your stool, and your stools will float. So remember from our pancreas lecture that our pancreatic acinar cells will produce these pancreatic enzymes. They'll flow through the ducts and make it into the main pancreatic duct and into our digestive tract to help out with breakdown of proteins and fats. So here's a fat, it'll get broken down into the smaller globule and everybody's happy. Again, though, if there's a blockage at the main pancreatic duct, what can happen is that you lose all these enzymes in the lumen. These fat globules don't break down and they're going to get excreted in the stool, causing steatorrhea. Hepatosplenomegaly can be caused with an obstruction because if you block this region here, you'll get a backflow to both the liver and gallbladder. So you can get hepatomegaly. Splenomegaly you can get for a few different reasons. I'm going to show you the most common reason you get splenomegaly in liver problems. Most of the time, your portal system is draining up into the liver. But if you have any blockage or obstruction in that region in your liver, it can actually cause a backflow. And so that backflow can ultimately reach the spleen and kind of push and cause higher pressures in the spleen, and that can cause splenomegaly. This is just one of a few different ways you can have splenomegaly. I just wanted to point that out while we're here. And we talk about that more when we talk about portal hypertension and other liver defects. Increased cholesterol should also make sense. We've talked about how having this obstruction can increase your bilirubin because it's a component of bile. So because cholesterol is also a component of bile, it should come as no surprise that having more bile in your bloodstream means you have more cholesterol in your bloodstream as well. And just like we talked about, conjugated bilirubin is also going to be elevated. The same reason we talked about with the dark urine, we have our unconjugated bilirubin. It gets conjugated in the liver, and that's why you'll see more conjugated bilirubin now on laboratory evaluation if you have biliary obstruction, because it's already gone through that conjugation. This is a good time to just talk about when unconjugated bilirubin would be elevated, just so you have a sense of what conditions to look out for on a test if the indirect or unconjugated bilirubin is high versus the direct or conjugated bilirubin. So the first thing, the most likely way they're going to test unconjugated hyperbilirubinemia is through hemolysis. So if we have a bunch of red blood cells, we already talked about how when they break down naturally, they release some unconjugated bilirubin. So if you have a condition where you're hemolyzing, where you're destroying your red blood cells for whatever reason, you can imagine that you can get a huge influx of unconjugated bilirubin in your bloodstream. And that can actually overwhelm the capacity of your liver to conjugate all these. And so if you check your blood levels, you're going to find a ton of unconjugated bilirubin. Another thing to keep in mind is that liver pathologies could cause an unconjugated hyperbilirubinemia. Again, if you imagine these guys are always trying to get conjugated when they're floating in the bloodstream, but if your liver's not functioning that well, this whole process might be deficient and you might end up with more unconjugated bilirubin than you would like. Let's move on to some other lab values. So the classic, what they call cholestatic liver function tests or obstructive liver function tests that I talk about in the liver section is having elevated conjugated bilirubin and elevated alk phos. We already talked about the conjugated bilirubin. So now let's go with what's alkaline phosphatase. So alkaline phosphatase is an enzyme that has a lot of activity in our liver, bones, and kidneys. So you can see alkaline phosphatase here, and it can be part of the bile. So it kind of flows down the same way that everything else does. So if you have an obstruction, you're going to have a lot more alk phos in your bloodstream, and so you can measure that. With that said, alk phos is not exclusive to the liver. So if you ever have a bone or a kidney problem, you can also be leaking out alk phos. So if you have an elevated alk phos, it doesn't necessarily mean you automatically have biliary obstruction. You also have to consider other things like Paget's disease of the bone and things of that nature. Gamma glutamyltransferase, or GGT, on the other hand, is much more specific to the liver. So if you have GGT, if you have a biliary obstruction and GGT leaks out, you'll have elevated GGT. But on the contrary to alk phos, if you had a bone or a kidney issue, your GGT is still going to be normal. So it's a lot more specific to the liver pathology than alk phos is. Decreased urine urobilinogen. This is one of the more low yield points, but I think it's very easy to understand. So I'm just going to point it out for you. Uh, how I think of urobilinogen is urobilinogen to me is a measure of how much bilirubin is in your gut, in your GI tract. Okay. So we know that conjugated bilirubin can make it into our GI tract. And from there, this can be deconjugated by our intestinal bacteria into unconjugated bilirubin and subsequently deconjugated more to your urobilinogen. So the more conjugated bilirubin that you have in your GI tract is directly proportional to the amount of urobilinogen that you will have in your that will be formed in your body. This urobilinogen can do a few things. As we saw before, this can get transferred into stercobilin, which causes your brown stool color, and which is why up here when we talked about pale stool, I was alluding to the fact that bilirubin is responsible for this dark pigment, and it's through this process that bilirubin provides that dark pigment as stercobilin. Uh, Instead of being converted to stercobilin, it can also be reabsorbed and excreted in the urine, which would cause urine to have its yellow pigment color. And so we can measure this. And like I said, the amount of urobilinogen that's in our blood is directly proportional to the amount that of conjugated or unconjugated bilirubin that makes it into our GI tract. So why is this important? So this can be important because if you think about let's say somebody comes in with jaundice and you know they have a really high total bilirubin and you're trying to figure out, is this hemolysis? Is this obstruction? Sure, on a test, they'll give you the classic unconjugated bilirubin is probably hemolysis, conjugated is probably some obstructive pattern. But what you can do here is you can kind of use this to guide your judgment too if they give you this on a test. If you have an obstruction here, what's going to happen is that you're going to lose all that conjugated bilirubin into nothing's going to make it into the GI tract. So you will have very low urine urobilinogen levels. But on the other hand, if you had something like hemolysis, where you have a ton of unconjugated bilirubin, a lot of that still will make it be converted to conjugated and ultimately flow down here into your GI tract. So you will get an increased urine urobilinogen level in things like hemolysis because there's nothing stopping all of that bilirubin from eventually making it into the GI tract. So it's just a differentiating factor. Like I said, it's a little bit lower yield than others, but I wanted to point that out. Now that we've gone over both the anatomy and physiology of the gallbladder and bile ducts, let's talk about several conditions. And I've broken this down into two categories. We're going to talk about all the conditions related to gallstones, and then we'll go over all the other conditions affecting your bile ducts that aren't necessarily gallstone related. So here's all our gallstone related conditions that we're going to go over. And here's the other ones. And so let's start with each of these because they're all related in some way. So it's quite simple once you have this framework in place. Before we talk about each of the conditions of gallstones, as far as the complications that can arise, let's go over what exactly a gallstone is. So gallstones are going to form when there's an imbalance in bile concentration. Remember from before, we talked about bile being 95% water. It also has bile salts and acids, cholesterol, bilirubin, and other compounds. So I want you to view this as a scale between water and bile salts, helping to dilute the bile and decreasing your risk of gallstones, versus these other compounds, cholesterol and bilirubin, which is going to concentrate the bile and increase your risk of gallstones. So there's kind of this back and forth between those two compounds versus the other two. So what causes gallstones? Well, gallbladder stasis can. If bile's not moving, you give it more time to start to concentrate and form actual precipitated masses. As I just mentioned, if you have any decreased water or bile salt levels, that's going to concentrate the bile, and that can cause gallstones. Or on the other hand, if you have increased levels of cholesterol or bilirubin, that can also cause a problem. So gallbladder stasis, let's talk about the three causes briefly. Gallbladder stasis would prevent bile excretion, and this can lead to an increased risk of stones. So if you could imagine, here's our bile. If it's flowing out this outflow tract, then we have no problems. But the problem is if it's just sitting there for too long, you can start to develop gallstones. What causes gallbladder stasis in the first place? Oh, pregnancy is a common contributor, and that's because progesterone promotes gallbladder stasis, so you're at higher risk of gallstones in pregnancy. Another thing is total parenteral nutrition, which just means that all your nutrition's coming in through an IV line. Nothing's coming in through your GI tract. This is in people who are very sick. And in TPN, the lack of nutrition in the gut decreases our CCK release, which will subsequently decrease our gallbladder contractions. So normally, if you or I had some food, it would enter the duodenum, that would end up in the duodenum. It would stimulate CCK, excuse me. Remember, amino acids and fatty acids can stimulate your eye cells to secrete CCK or cholecystokinin. That cholecystokinin will ultimately interact with the gallbladder and cause the gallbladder to contract, and you'll end up with bile in your duodenal lumen. The problem with total parenteral nutrition is that you lose any sort of fatty acids or amino acids in your gut. So your eye cells are not going to be producing that CCK, which will make it so this bile is not contracting out and you can form a gallstone. Another cause of gallstones is decreased water or bile salt or acid levels. So if either of these are reduced, you're going to increase your risk. So for decreased water, that should be somewhat straightforward. Any condition that causes dehydration, or any condition that causes dehydration will increase your risk of gallstones. And for decreased bile salts and acids, there's a few conditions to keep in mind here. One we've talked about in both the small intestine and colon lecture is Crohn's disease. And so Crohn's disease can decrease bile acid reabsorption. And we actually talked about it earlier in the physiology section, where bile, keep in mind, bile is not reabsorbed with the fat micelles here in the enterocytes, and instead it goes all the way down to the terminal ileum for reabsorption. And in conditions like Crohn's disease, you lose a lot of your architecture of your terminal ileum, and so you're not able to absorb bile, and you can get bile salt deficiency. And so that's why Crohn's has an increased risk of gallstones. A cystic fibrosis can also cause decreased bile acid reabsorption. What's happening here is that in cystic fibrosis, you don't have, oftentimes there's a lot of viscous fluid in your pancreatic duct, which we talked about, and that's why it's one of the common causes of pancreatic insufficiency. So if we don't have enough pancreatic lipases in our duodenum or in our GI tract in general, what's going to happen is that we aren't even able to break down these fat globules into these smaller micelles. So you're going to end up with a lot of fat globules traveling through your GI tract, and bile will still be attached to that. And if bile is attached to that, it's not going to be able to get reabsorbed at a healthy rate. And without the bile salts and acids, you're going to lose a lot of the ability to dilute your bile. Liver cirrhosis can also cause this because of decreased bile acid production. Remember that liver creates bile, so if there's any defect in this, that could technically change the concentration levels of each of the components and increase your risk of gallstones. So cirrhosis, you can get that. I think that's the lowest yield one. The Crohn's one by far here is the most important. You have to know the mechanism by which Crohn's causes gallstones, and this is the way it does it. Now let's talk about what conditions would cause increased cholesterol or bilirubin levels to concentrate the bile and cause gallstones. So the two subtypes of gallstones, if you haven't guessed already, are cholesterol stones and bilirubin stones. So let's first start by talking about cholesterol stones. So cholesterol gallstones, 80% of your gallstones are cholesterol stones. You could see a bunch of gallstones there. Most of them are radiolucent, which means if you take an X-ray, they're going to be translucent. You're not going to be able to see anything, which is why we do ultrasounds. They're yellow-green in color. And here's, like I said, here's dozens of cholesterol gallstones. And the risk factors for cholesterol gallstones specifically are often referred to by the mnemonic of the 5 Fs. That's going to be females, people with obesity or fat people, fertile, 40, and first people. Okay, so let's talk about this common mnemonic that's used. So female, why would females be at higher risk of cholesterol gallstones? So females produce more estrogen, and estrogen is a driver of cholesterol synthesis. So that could increase your risk of cholesterol gallstones. For those people with obesity, the increased total body cholesterol can also be a driver to increasing the concentration of cholesterol in the bile. And another point that's related to this is that if you have somebody who's losing a lot of weight, that also mobilizes the cholesterol from the adipose tissue. And that'll temporarily increase the amount of cholesterol in your bloodstream, in your bile. And so then you're at a risk of gallstone formation during that time as well. So fertile stands for pregnancy. And what I want you to remember with pregnancy is that I'll keep it simple and just remember that pregnancy is basically a significant increase to your progesterone and estrogen levels. And we've talked about what both of these hormones do in the bile already. We've talked about estrogen right here promoting cholesterol synthesis. And earlier we discussed that progesterone can increase gallbladder stasis. So it's kind of like a double-edged sword there's two risk factors right there that can increase your risk of cholesterol, gallstone formation. 40, the reason why this happens, cholesterol gallstones are most common around that age is because in your 40s to about the age of 60, your concentration of cholesterol in your bile is highest. And then before that, and even after that, the concentrations aren't as high. And because of these concentration changes over the lifespan, it's actually pretty rare to get gallstones as a very, very older person, like in your 70s. And in those populations, if somebody's developing gallstones for the first time, like much later in life, you should consider cancer as a potential driver that's kind of changing the concentrations in that region. And for first people or fair skin, so there's genetic factors that can increase the risk of gallstones in certain populations. So just keep that in mind. So those are the risk factors for cholesterol gallstones. Let's discuss bilirubin gallstones in some detail now. So the other 20% of gallstones are bilirubin gallstones, and these are caused by unconjugated bilirubin in our bile ducts. Remember that so far we've only talked about conjugated bilirubin making it into our bile ducts. As the red blood cells broke down, they released a ton of unconjugated bilirubin, and then our liver was able to conjugate them and put that conjugated bilirubin in the bile. You can see some gallstones right here, bilirubin gallstones. These are black gallstones. And that leads me to my next point, that there are two different types of bilirubin gallstones, black and brown pigment stones. And both of these are caused by different processes, but they both ultimately will lead to this unconjugated bilirubin in your bile ducts. So let's go over these different types of pigment stones. So black pigment stones arise due to excessive hemolysis. They're radio-opaque, which means you can actually pick these up on an X-ray. And the mnemonic here that I remember black versus brown gallstones, I remember black by when RBCs crack, the stones are black. So when you have a lot of hemolysis, I remember that as black pigment stones. Brown pigment stones, on the other hand, are because of recurrent infections in your biliary tree. These are radiolucent, so they're translucent. And again, the mnemonic I remember for this is when the infection goes down, the stones are brown. So let's show this in a picture format so it can reinforce it. So bilirubin stones in general are both caused by unconjugated bilirubin, making it into your bile duct. Black pigment stones form because of hemolysis. So if we have our red blood cells, imagine most of the time, any broken down unconjugated bilirubin will be converted to conjugated bilirubin. And so we don't have any risk of bilirubin gallstones in this case. However, if you have a ton of red blood cells that are all dying, they're just releasing a vast amount of unconjugated bilirubin. And what's going to happen is that unconjugated bilirubin is going to overwhelm the liver. And some of it can be conjugated, but a lot of it's going to stay unconjugated because there's just so much going through it at once. And some of that unconjugated bilirubin that makes it into your bile ducts can increase your risk of bilirubin gallstones, specifically the black pigmented stones. And remember, when RBCs crack, the stones are black. Brown pigment stones, on the other hand, are related to biliary tree infections. So what's happening here is that we have our unconjugated bilirubin. It gets conjugated. That conjugated bilirubin is a component of your bile, and that gets released. Everything so far has been completely normal physiology. What happens here, though, is that if you have an infection in your biliary tree, that bacteria that's in your biliary tree, whether it's in your gallbladder or your ducts directly, can deconjugate some of that conjugated bilirubin into unconjugated. And that can ultimately form brown pigmented stones. So remember, for the mnemonic for this, remember that when an infection goes down, the stones are brown. Another thing I just added here at the bottom, this you don't need to know this for step 1, but liver disease can also cause bilirubin gallstones due to impaired conjugation. That should make some sense intuitively. If you can't conjugate it, then some more some more unconjugated bilirubin can get in there. But it actually forms a mixture of brown and black stones. And there's more, it's a little bit more complicated than that. You do not need to know that for step 1, but you definitely need to know how to tell the difference between a black and a brown pigment stone and what conditions cause it, hemolysis versus infection. And let's see, I even added a slide on this. Again, I don't think this is that important. This is just about how liver disease can basically cause more unconjugated, and it forms a mix of brown and black stones. Not tested ever on step 1. I don't know why I kept that in there. Maybe just for completeness sake for you guys. Here's the slide that everything we've been talking about. I tried to condense it into one slide because it can be a little confusing sometimes. Remember that the risk factors, that gallbladder stasis, that imbalance where you have either low water, low bile salt or acid, or increased cholesterol or bilirubin, that increases your risk of all types of gallstones. Obviously, if you have increased cholesterol, that's going to increase your risk of cholesterol gallstones, and increased unconjugated bilirubin will increase these two. And then the pathogenesis is a little different. Cholesterol is naturally going to be related to increased cholesterol concentration in the bile. If we talk about black pigmented stones, that's because of increased unconjugated bilirubin making it into the bile, usually through something like hemolysis. Whereas brown pigment stones, not necessarily related to increased systemic bilirubin, it's more related to bacteria that exists that can deconjugate that bilirubin. into unconjugated. So our risk factors for cholesterol stones were our 5Fs. Anybody who's female, fat, fertile, 40, or first people / fair skin, those are all risk factors for cholesterol gallstones specifically. For black pigmented stones, we know that it's hemolysis, and our mnemonic was when RBCs crack, the stones are black. And for brown pigmented stones, infection in the biliary tree is a risk factor. And so when infection goes down, the stones are brown. I also included the radiographic findings of cholesterol being translucent, black is radio opaque, and brown is radiolucent. This is, I don't know if I was tested on the translucency of this, but just remember that black stones are the only ones that can be seen. So they're the only radio opaque stones. So we talked about the pathophysiology of how gallstones form, whether it's cholesterol or bilirubin stones. Now I want to talk about what that looks like in a clinical vignette. How are you going to see somebody who actually has gallstones? So most of the time, if you have a gallstone, you won't even realize it. Vast majority of cases are asymptomatic. But what can happen is that depending on where that gallstone is in your entire biliary tree, you can have complications, and those complications can be symptomatic. You can diagnose gallstones with a right upper quadrant ultrasound. As we discussed, most of the gallstones are radiolucent, so translucent, so you can't see them on X-ray, but right upper quadrant ultrasound can give you a pretty good idea of gallstones. Most of the time, this is treated with a cholecystectomy. You can live without your gallbladder, and the bile that you need to digest things can flow straight from your liver down into your duodenum if you have to. So cholecystectomy is the standard of care. Sometimes some patients are given ursodiol. Most of the time, this is just for patients who can't tolerate the surgery in the first place. And ursodiol works to decrease the cholesterol secretion into the bile. So again, that would help flip the scales, make the bile a little bit more dilute, and hopefully decrease the risk of gallstones. But like I said, cholecystectomy is the standard of care in most settings, especially if you're symptomatic. So I just mentioned you can be symptomatic if you have complications of gallstones. Here's all the complications of having a gallstone. And that's why I wanted to put this all into one section for you so that you can understand the similarities and the differences between each of these 6 conditions. So let's draw this pictorially. Biliary colic, the first of the 6 complications we'll go over, is caused by the stone contracting against the cystic duct, and that can cause inflammation. Cholecystitis is when a gallstone gets stuck in your cystic duct. Choledocholithiasis is when the gallstone gets stuck in the common bile duct. Gallstone pancreatitis is when it gets stuck in the main pancreatic duct. Ascending cholangitis is when a gallstone gets stuck in any of these regions, but most commonly the main pancreatic duct or the common bile duct, and it gets stuck and an infection can form proximal to that blockage. And lastly, Gallstone Ileus is when a very, very large gallstone can make it into your GI tract and it gets stuck in your intestine. So let's start with biliary colic, which is when the stone, it's still in the gallbladder, but it contracts against the cystic duct. So just to clarify, colic is where you have severe fluctuating pain. That's when they describe colicky pain. You hear it in a few different conditions, gallstones being one of them. Kidney stones can cause colic. Small bowel obstruction can cause colicky pain, where you have the pain and then it goes away, and then you have the pain and then it goes away. And so why is it causing this colicky pain that comes and goes? Well, what's happening is that each time your gallbladder is contracting, that gallstone can start rubbing against the cystic duct and causing a little inflammation. And then when your gallbladder relaxes, that stone goes away. And then when it contracts, it does the same thing. So that's why you get this severe fluctuating pain in biliary colic. So again, in pictorial format, if we have bile here, let's just say most of the time that bile will flow right out. But if we have a gallstone already formed in our gallbladder, what can happen is that once the gallbladder contracts, it'll push against that cystic duct, cause some inflammation and pain, and then over time it'll relax, and then it'll get contracted again later on. It'll push against that, and so you can see that colicky pain pattern happening right here. So this will present with a few different things. It can present with right upper quadrant pain, with nausea and vomiting. The right upper quadrant pain should make sense to you because we're in the right upper quadrant with the liver and the gallbladder. Postprandial should also make sense. So after meals, you're going to have more pain. And that's because, especially with fatty foods, and that's because when you eat meals and you have fatty foods going to the duodenum, we're going to have our eye cells in our duodenum secreting that cholecystokinin and causing that gallbladder contraction. And once it contracts, you can get that gallstone getting stuck there and causing inflammation. The pain may also radiate to the right shoulder, and we'll see this with a couple other biliary complications. The reason that happens is because right above your liver is your diaphragm, which is innervated by the phrenic nerve. And so that inflammation can actually reach the nearby phrenic nerve and travel all the way up and cause referred pain to the right shoulder. You treat this, like we talked about gallstones initially, even if they're asymptomatic, you can treat cholelithiasis with a cholecystectomy, especially if you have symptoms like biliary colic and you can tolerate the surgery. It's a highly effective intervention. So now let's talk about cholecystitis, and we'll go over some of the differences between the two. So in cholecystitis, you have inflammation of the gallbladder, as the name suggests, and there's a few different subtypes of cholecystitis. The one we've kind of been talking about so far is acute cholecystitis, specifically acute calculous cholecystitis, which just means cholecystitis caused by a calculi or a stone. You can get chronic cholecystitis as well, and you can also have a rare type of cholecystitis called acalculous cholecystitis, which is where you're getting inflammation of the gallbladder unrelated to any gallstone in the way. This is usually caused by really critically ill people who have gallbladder stasis, and that gallbladder stasis can eventually lead to inflammation in that gallbladder. And we'll talk about each of these three subtypes. I first want to start with the gallstone related subtype. And so the reason why you're getting inflammation of the gallbladder is because you have a stone that's stuck within your cystic duct. So here we have our picture here of bile flowing down and everybody's happy. But in acute calculous cholecystitis, you're going to have a gallstone stuck there. And because there's nothing that can escape, you can easily have inflammation over time. This will present with a fever and leukocytosis, which shouldn't be a surprise to you because whenever you see that itis, I want you to think about that elevated white count and fever in most cases. You'll again have right upper quadrant pain. You have right shoulder pain for that same reason we talked about before with biliary colic, and you can have some nausea and vomiting as well. They also like to test on Murphy's sign, which is a physical exam maneuver that we can do. And what that is where you'll have somebody take a deep breath while you're palpating their right upper quadrant, and they'll quit breathing deeply for a moment because of the pain. So let me show you what that looks like. In Murphy's sign, the provider will put their hand in the right upper quadrant below where the gallbladder is. And when you take a deep breath, what's happening is that your lungs are expanding and all your abdominal contents are getting pushed down as that diaphragm moves down. So if that's our diaphragm, everything's starting to get pushed down when you take that deep breath. And part of what's getting moved down is our gallbladder here. And when our gallbladder moves down and makes contact, when this inflamed gallbladder makes contact with your hand, that's going to cause a really severe pain. And so during that deep breath, they're going to basically stop breathing very quickly because of that pain. So how is this diagnosed? Just like you're going to see this very common. where right upper quadrant ultrasound can diagnose some of these gallstone-related diseases. You might have to use something called a HIDA scan. Let's say you have a very high clinical suspicion. This person meets all the risk factors uh, for gallstones, or they've had a history of gallstones in the past, and they're having the symptoms. They have a positive Murphy sign, fever, leukocytosis. Like you are sure that this is cholecystitis. And then you do the right upper quadrant ultrasound and you can't find any gallstones. Now you're like, what do I do? So if your suspicion is high, you can do something called a HIDA scan. And the classic thing on test that they'll say is that if you fail to visualize the gallbladder on a HIDA scan, that's suggestive of cholecystitis. So what does that mean? So basically in a HIDA scan, what you do is you release all this contrast into the bloodstream. And that some of that will end up getting picked up in the liver. It'll flow through the bile ducts just like bile does, and then that'll get excreted. And so if you measured if you saw a HIDA scan for this person, they'd have contrast in all these regions to some extent. If you have a gallstone though in your cystic duct, then that contrast could never make it into the gallbladder in the first place. So when you'd do a HIDA scan here, you would have a failure to visualize the gallbladder in this case. Here's a normal HIDA scan where everything's working well. And I want you to recognize that the gallbladder here is visualizable in each of these. They won't give you a HIDA scan photo, but I just wanted to explain the process. And that's why a failure to visualize the gallbladder is suggestive of acute cholecystitis, because the contrast can't make it in through the cystic duct and into the gallbladder. So you treat this with an urgent cholecystectomy. You want to get this done quickly because before this inflammation gets any worse. And the complications of this, if you have inflammation in your gallbladder, that could always, just like appendicitis had that same risk of rupture. Anytime you have that inflammation in one of your visceral organs like this, you run the risk of rupture. And another complication is chronic cholecystitis. So this is a good segue to talk about chronic cholecystitis. This is, as the name suggests, chronic inflammation of gallbladder, usually due to untreated acute cholecystitis. And this can lead to a calcified gallbladder, also known as a porcelain gallbladder. Here on this X-ray, you can actually see the lining here of your gallbladder, which is unusual. So that's known as the porcelain gallbladder, suggestive of chronic cholecystitis. The complications that can arise from chronic cholecystitis is that you have so much inflammation in this area over time that it can increase your risk of gallbladder cancer. And as you might have guessed, treatment for this is a cholecystectomy. Who would have thought? I'll just briefly mention acalculous cholecystitis. It doesn't really fit in with our whole gallstone pathologies that we've been talking about so far, but acalculous cholecystitis means cholecystitis that forms without any stone. You'll see this in critically ill patients. And what's happening here is that instead of obstruction causing the problem, it's actually just gallbladder stasis. They're so sick, there's no flow from the gallbladder out to the duodenum that you're just going to eventually cause inflammation and ischemia to that region. So here you go, no obstruction, critically ill, you get significant gallbladder stasis, which causes inflammation and ischemia. The one thing they love to test, I don't think I've ever seen a question that hasn't had this specific answer choice. They'll always bring somebody who has, like, they'll say this critically ill person, they have all the symptoms of cholecystitis, there's no stone detected, what's happening? Or they'll say, like, what bug is causing this? And so the very common bug that causes acalculous cholecystitis in critically ill patients is CMV. So do not forget this. CMV is a very common contributor to acalculous cholecystitis. So now let's kind of go back to our gallstone-related pathologies. We just talked about acute cholecystitis. What happens when we have the stone make it to the common bile duct before it gets stuck? So that's Choledocholithiasis. As I just mentioned, that's a gallstone in the CBD. So this will present with biliary obstructive symptoms, which we've talked about a lot earlier in this lecture on the physiology section. So this can cause jaundice, elevated alkaline phosphatase or gamma glutamyl transferase, elevated conjugated or direct bilirubin. And remember, it can cause all those other symptoms that we discussed earlier today too, like the dark urine, increased cholesterol, among other things. So remember that the liver creates bile, it's sent to the gallbladder, and when the gallbladder contracts, it flows all the way down into the lumen. In biliary colic, we didn't see any of these biliary obstruction symptoms because even if the stone gets stuck here and you lose this outflow tract, you still have a lot of the bile flowing out and into your GI tract. Same thing with acute cholecystitis. Yeah, we lose this area here, so we can't get this out. But most of the bile that's getting produced by the liver can easily escape out. So you're not going to get obstructive symptoms in biliary colic or acute cholecystitis. The problem that we're going to start running into with choledocholithiasis, as well as gallstone pancreatitis, which is when it's stuck in this region, and ascending cholangitis, when you have something stuck with an infection, you're going to start to see obstructive symptoms because bile cannot escape now, and it'll actually leak out into the bloodstream. So from our physiology section on the gallbladder that we talked about earlier today, you can see that this whole host of biliary obstructive symptoms now can occur as a result of this blockage, because all of that's getting released into our bloodstream now. So the complications of having a stone in your bile duct, in addition to that obstructive symptoms, choledocholithiasis can eventually cause gallstone pancreatitis if it keeps moving down to block the main pancreatic duct, or it can cause ascending cholangitis if that stone stays long enough for a bacterial infection to start to brew proximal to that obstruction. So let's talk about these two complications. So gallstone pancreatitis is when the stone makes it all the way down where it lodges in the main pancreatic duct / the CBD here. So in gallstone pancreatitis, we know where the stone is. This prevents outflow of pancreatic fluid. And when you have blocked outflow of pancreatic fluid, that can actually lead to acute pancreatitis. So again, if the stone makes it all the way down here, you're going to have, most of the time, our pancreatic enzymes are free flowing and they're trying to escape into the lumen. But if they get stuck there, then you can have trypsin be prematurely activated within our pancreatic ducts, and that can cause inflammation or acute pancreatitis. And when we talked about acute pancreatitis in our pancreas lecture, I mentioned that gallstones are very, very common contributors. Where a gallstone blocks the duct, it's activated and you have inflammation. And even here you can see that the most common cause of acute pancreatitis is gallstones in the first place. 40 to 70% of gallstones, depending on which resource you use. 40 to 70% of all cases of acute pancreatitis are caused by gallstones. So very common. How does this present? The presentation is pretty obvious. It's going to be pancreatitis, but it'll also be biliary obstructive symptoms. And that should give you an idea. Whenever you see somebody with the classic pancreatitis picture, epigastric pain radiating to the back, super high lipase levels, and characteristic imaging findings, depending on, you just need 2 out of those 3 for the diagnosis. Whenever you get the diagnosis of pancreatitis, the first thing I want you to do is think about why they're having pancreatitis. Is it alcohol related? Is it triglyceridemia? Is it hypercalcemia? Is it gallstone alcohol? Scorpion bite mumps. There's so many, ERCP, there's so many different causes. And so on a test, once you see somebody with classic pancreatitis signs, oftentimes the first thing you'll do is order a right upper quadrant ultrasound to see if gallstones are the problem. Or sometimes they'll give you liver function tests, and if those show elevated conjugated bilirubin, elevated alk phos, that should give you an idea, or elevated GGT levels, that should give you an idea that, okay, it's probably going to be caused by a gallstone because you're having obstructive symptoms and pancreatitis. So again, not only in this case, if there is a gallstone lodged here, not only are your pancreatic enzymes obstructed, but your bile is obstructed too. So you'll get the same problems that we've talked about before. I'm going to go back. You get the same problems that you talked about before with an obstructive pattern. Ascending cholangitis is a little different, and this is actually more dangerous. This is a life-threatening infection of your biliary tree with almost a 10% mortality rate on some resources. So what's happening here is that the stone is blocking either the common bile duct or it makes it down further. But the important thing with ascending cholangitis, as the name suggests with the itis, is that you're having a bacteria ascend through the tree and causing an infection or inflammation. So because the bacteria is ascending from your GI tract, you're going to commonly get your gut flora like E. coli, Klebsiella, and Enterobacter. Those are usually the culprits of ascending cholangitis. So normally, if you have bacteria in your GI tract, if they so happen to find a way into your biliary tree on accident, your bile can just wash them back down into your gut, and there's no problem with that because that's where they belong usually. However, if there's a stone blocking it, sometimes these bacteria can kind of sneak around that stone and get into here, and now there's nothing to really wash the bacteria away. And now they're in a spot where they can cause serious damage. So there's a triad and a pentad that you have to know with ascending cholangitis. So first one I want you to realize is the Charcot's triad, which is fever, jaundice, and right upper quadrant pain. And the fever and right upper quadrant pain should make sense. We've actually seen this we saw this in acute cholecystitis, right? We saw that inflammation can cause right upper quadrant pain and fever. But the difference with ascending cholangitis is that because it is in the common bile duct, it should also cause obstructive symptoms like jaundice. So here again, if you have bile leaking out into your bloodstream now, you're going to get all these biliary obstructive symptoms are possible in ascending cholangitis, in addition to that fever and right upper quadrant pain. Now, in severe cases of ascending cholangitis, they're going to develop Raynaud's pentad, which basically just means they're in shock. Like they're so sick now that their body's going into shock. So you're going to see all those three symptoms that we talked about. So you're still going to see Charcot's triad. You're going to start to see altered mentation, and you're going to see hypotension. So basically, this person's hypoperfusing now. They're going into shock, and that's why you get this Raynaud's pentad. On laboratory evaluation, you're going to get an elevated white count, which again shouldn't surprise you. You're going to get obstructive labs like elevated ALK phos, elevated C-Bili, elevated GGT. And again, that shouldn't surprise you because in our biliary obstruction symptoms, we have those as part of this subset of symptoms. And that's all you need to know for ascending cholangitis. Oh yeah, sorry about that. That's all I had for ascending cholangitis. Now let's talk about Gallstone Ileus, which is kind of its own category of things. So how does it make it into the GI tract? What actually happens here is it doesn't take the same route that the other gallstones have been taking. Instead, you're going to have this huge gallstone that can't even make it into the cystic duct, and it's just going to be pressing against the wall of your gallbladder. And that pressure over a significant amount of time will slowly erode away the gallbladder wall. And eventually there's going to be a fistula that can form between your gallbladder and your duodenum directly. And once that happens over time, that gallstone can actually sneak into your small intestine, and it'll travel all throughout your small intestine, and your ileocecal valve is the smallest point of your intestine. So it'll travel all the way down, and it usually gets stuck right at that ileocecal valve in the right lower quadrant. So again, if we have this huge gallstone, normally gallstones would be able to flow out this outflow tract when the gallbladder contracts, but this gallstone's just too big to even fit through the cystic duct. So it's just going to sit in your gallbladder, and over time, it's going to cause pressure necrosis of that wall. That once that necrosis has gone up, then a fistula can actually form between the gallbladder and the small intestine, and that gallbladder can enter the small intestine. And like I said, that gallstone will now travel down the small intestine until it reaches the ileocecal junction at the right lower quadrant. So You could see it here. Gallstone forms, it moves along the small intestine and makes it to the ileocecal junction before it gets stopped. And so imaging findings, they could mention that they find something in the right lower quadrant or you palpate something in the right lower quadrant, but more often than not, they like to test you on the concept of pneumobilia. So pneumobilia is air in the biliary tree, and that's unusual. So normally we have air in you can have air in your GI tract, that's fine. But if the air ever tries to get into your biliary tree, we have our sphincter of Oddi and a few other things that seal this area off and that you don't allow significant amounts of air inside your biliary tree. In Gallstone Ileus, though, you form this fistula between your gallbladder and your GI tract, and so that air can actually start moving into that region, and you'll find air in your biliary tree on imaging studies. And like I said, you might actually see a gallstone in the iliac fossa. I've yet to see a practice question or a test question that shows an image of this, but they sometimes will mention that. I've seen them verbally mention that you have something in your, right lower quadrant. And because you have this massive gallstone that's kind of obstructing the ileocecal valve, then you could obviously get small bowel obstruction in some cases. Okay, that's enough discussion on gallstone-related conditions. I think we covered that pretty well. Now I want to move on to a few other conditions that involve the bile ducts but aren't related to gallstones in any way. And we have two autoimmune conditions, and then we have two types of cancers that we have to go over. So primary biliary cholangitis, previously known as primary biliary cirrhosis, is an autoimmune condition. So let's go over that. So what happens here is that you have some sort of autoimmune reaction. Your body's attacking your own cells, and ultimately you're destroying your intrahepatic bile ducts. So what that'll look like is this region here, through an autoimmune reaction, will start to get damaged and destroyed because of this whole autoimmune process. Classically, you're going to see this, and especially on tests, they always give it as a middle-aged woman with a history of some sort of autoimmune disease. So whether that's Sjogren's, hypothyroidism, type 1 diabetes, RA, celiac, it'll almost always be in a middle-aged woman with some sort of autoimmune history. It's classically associated with Sjogren's, but on tests, any of these are possible. And this middle-aged woman who has this autoimmune condition will usually present with really bad pruritus, intractable itching. It could present with fatigue as well, and biliary obstructive symptoms like jaundice. So the key, I think Boards and Beyond told me this, that always consider, if you ever see a woman with pruritus, the first thing you should consider on test is PBC. And I didn't believe that at first when Boards and Beyond said that, but I don't remember seeing a PBC question where pruritus was not mentioned. So it's actually a really high yield symptom. If you ever see a middle-aged woman with pruritus, first thing you should think about is PBC. And so pruritus is forming because you have so much inflammation in this area that some of the bile leaks out. And remember, a component of bile is bile salts. And if you have too much bile salts in your bloodstream, you can get pruritus. And remember, not only the pruritus, you can also get obstructive symptoms like jaundice, and that's kind of for the same reason. Whenever you have all this bile entering your bloodstream, you can get all your biliary obstructive symptoms. To diagnose this, and this is commonly tested, they love their antibodies, and they love trying to confuse you about the antibodies between this, PSC, and autoimmune hepatitis. So I'm just going to give you some mnemonics to kind of go over each of those. So this is a slide that you'll see later on when we talk about PSC and autoimmune hepatitis as well. We're talking about PBC right now. I always remember PBC from my mnemonic, Itchy Mama. And I remember, I don't know if you've ever played the game Cooking Mama or whatever it's called, but that kind of reminds me of Itchy Mama. So why I picked this mnemonic to remember PBC, I remember the itchy, obviously, for pruritus. I remember the mama to remind me that this happens in middle-aged women, or moms. And then I also remember mama for the AMA, which is the anti-mitochondrial antibody that's seen in PBC. While we're talking about different autoimmune conditions, I'll just show you how I remember each of these. P-ANCA, I remember P-ANCA as a marker for ulcerative colitis, just like Crohn's has the anti-Saccharomyces cerevisiae antibody, the ASCA. So as long as you remember that ulcerative colitis is P-ANCA positive, when we talk about PSC, we'll learn that it's a complication of UC, so both of them are going to be P-ANCA positive. And lastly, for autoimmune hepatitis, when we talk about this in the liver section, I just want you to recognize that the liver is a smooth organ, and that's why hepatitis is the anti-smooth muscle antibody. Some people this will help out, some people it won't, but it really, trust me, if you learn it now, that's great, but a year from now, it's going to be hard to differentiate if you haven't looked it over. So this is a good mnemonic to kind of help you moving forward. You can also diagnose PBC, with a liver biopsy, and this is going to show you a lymphocytic infiltrate with granulomas. So here's a histologic representation of PBC, and just think of granulomas. I've mentioned this before in a few other lectures, that granulomas are basically your garbage cans of your body, and they store trash that can't be excreted elsewhere. And so here you have your lymphocytic infiltrate. All these little purple dots are all your lymphocytes, and you can see all these big granuloma garbage cans kind of existing as well. You can treat this with ursodiol. Remember, that's the medication that we sometimes used to treat gallstones in patients who couldn't have surgery. But ultimately, PBC, it requires a liver transplant. And there's the mnemonic again, itchy mama. So let's compare and contrast this to another autoimmune condition, primary sclerosing cholangitis, or PSC. So this is a chronic inflammation of not only the intrahepatic bile ducts, but also the extrahepatic bile ducts. So what that'll look like, here's PBC that we've been talking about. PSC also affects the bile ducts that are outside of the liver as well. And again, I want you to think about PSC as a complication of ulcerative colitis, because 90% of people, actually greater than 90% of people with PSC have some underlying inflammatory bowel disease. Most of the time it's UC, it can be Crohn's. On tests, it's always going to be UC. So just remember it as a UC complication, and I think you'll do quite well. This is from our colon lecture. And from our colon lecture, I mentioned that UC always starts at the bottom and progresses up. And I don't know if you remember this, I used the mnemonic of the first letter, the U, and I always remember that because the U ends right here, kind of does this loop right here, it's your inflammation starts at the bottom, whereas Crohn's disease starts with a C, and so that's why the inflammation starts on the left side of the screen here, and that's why the Crohn's usually has problems in this left side of your body right here, this terminal ileum, if you're looking at the body like this. I don't know if that helps, but in UC, it always involves the rectum, and the inflammation always progresses proximally. So you'll have inflammation here first, and then it can spread here over time, and then it gets here. And in PSC, how I remember it, this isn't exactly what's going on, but how I remember it is just that inflammation continues onward and finally reaches the bile ducts, and that's why you get PSC. That's kind of how I think about it in my brain. This will present in middle-aged men normally, and you'll get right upper quadrant pain, fatigue, and jaundice, but you'll also have UC symptoms, and that's kind of how that'll tip you over the edge. They'll either give you somebody who has a history of inflammatory bowel disease, or they'll give you somebody who has these bile duct symptoms, but then they also have these IBD symptoms. So you'll see this overlap, and that'll clue you in that it might be talking about PSC. There's a few important laboratory findings you should know about. Because there's obstruction, you'll still get those what are called cholestatic liver function tests. That's just a fancy term for the obstructive pathologies that we've been discussing. Elevated C-Bili, elevated GGT, elevated ALK phos. So nothing's changed there. And that's happening again because if you have bile here, it all wants to escape out and into your GI tract. But if you have all this blockage in the extrahepatic or intrahepatic ducts, it can flow out into your bloodstream and give you that laboratory picture. Again, it's P-ANCA positive, which is the same as ulcerative colitis. So that's an easy way to remember that. Histology, they like this. I mentioned the histology of PBC is that lymphocytic infiltrate with granulomas, and that's sometimes tested. I think that this onion skin fibrosis is a little bit more high yield. They're more likely to show you a picture, a histology slide of this, and ask you what's going on here. And so this is an onion skin fibrosis. If we have our bile duct here, you can see these onion skins, these concentric layers of fibrosis surrounding the bile ducts. On imaging, they also love this. They love this beating of the bile ducts. So this is a picture of, you can see your gallbladder here and all your bile ducts. And so what's happening here is that these bile ducts, in this case, are doing quite well, and there's no stricture. And in this case here, though, you'll see this classic beads on a string pattern with the bile duct. You can see a bead here, and then it kind of goes normal, and then you see another bead here. And they usually don't show you a picture of this on the test, but they will mention that there's some sort of alternating beading and stricturing. So why is that happening? So in PSC, what's happening is that you get this inflammation of the bile duct, and some of that inflammation will not be repaired, but instead be replaced by fibrotic connective tissue. And some of that connective tissue has contractile abilities and can push in and start to constrict the lumen and form this stricture here. And so if you imagine on cholangiography, you'll see this very small area, and then you'll see a bead, and then you might have a stricture elsewhere, and you'll see a small area, and then you'll see a bead. So the beaded areas are actually your normal areas, even though they look abnormal in that picture sometimes. And so the complications of PSC is that you can have an increased risk of cholangiocarcinoma and gallbladder cancer. So all that chronic inflammation can cause some problems. And again, that's a good segue into our last two conditions, which are the cancers. And these are pretty straightforward. For cholangiocarcinoma, you just have to know that this is a carcinoma of your bile duct cells. And this results from chronic bile duct inflammation. So a risk factor, as we just discussed, is primary sclerosing cholangitis, which in itself is a complication of longstanding UC in most cases. Another thing they sometimes test is that the Chinese liver fluke, Clonorchis sinensis, also increases your risk of cholangiocarcinoma. So that's another thing to keep in mind. And our last section here, our last disease is gallbladder cancer, gallbladder carcinoma. And so this is a cancer arising from the glandular cells within your gallbladder. And again, this is also a consequence of chronic gallbladder inflammation. I feel like we've made a point of saying any sort of chronic inflammation can increase your risk of cancer. We've seen it in chronic insults to your esophagus causing squamous cell carcinoma. We've seen chronic inflammation due to GERD causing like Barrett's esophagus and esophageal adenocarcinoma. Chronic gastritis can cause gastric adenocarcinoma. Chronic pancreatitis can cause pancreatic adenocarcinoma. I guess the only one that we don't really see it with is colon cancer, now that I think about it. That's usually from different genetic mechanisms or from the adenocarcinoma sequence. Anyways, I'm getting off track. Sorry about that. But yeah, chronic gallbladder inflammation causes gallbladder cancer. The risk factors for this is chronic cholecystitis, which we talked about earlier. And here's our picture of chronic cholecystitis with our porcelain gallbladder up here. And just remember that all this chronic inflammation increases your risk of gallbladder cancer. Another risk factor that they sometimes test is Salmonella typhi that can reside in your gallbladder, and so that can also cause gallbladder carcinoma over time. And so that's the end of this lecture. This is our second to last lecture together for this unit. and I'll see you next time for the liver section. So thanks, everybody.